Hey everyone, welcome. We're going to have an exciting panel today. We're going to be talking about aligning the advantages of flexible healthcare IT models with improved patient care. And we're going to have a really lively discussion. I think with COVID, we've all realized we have to be flexible. I think that's a necessity for every healthcare organization. Hopefully today we can provide some practical insights and perspectives on what healthcare organizations can do to really implement that and to navigate this world, right? So I think there's a number of important topics we're going to do here. I'm John Lind, the founder and chief editor at Healthcare IT Today, and I'm going to be moderating this discussion. Of course, if you're here watching live, we'd love to have your participation. If you have questions, if you have comments you want to throw in here, raise your hand, give me the, universal head nod, right? Like I got something to say, and we're happy to include you in the discussion as well. And let's go down the line and introduce all our panelists. And you want to start?
Hi, I'm Heather Hitchcock. I'm the Chief Marketing Officer of Medical Informatics. We're a partner to Dell, enabling virtual care and AI at scale. And I've been in healthcare, 30 years in product management for telemetry and wireless, and really been in the space of healthcare IT for about the last 15 years. So thank you for being here.
Welcome, Heather. Sharice, you want to go next?
I will go next. Hi, everybody. I'm Sharice Maynard. I'm a health IT strategist. I am one of the founders at Nostra Data Medical, and also one of the founders at Hit Like a Girl Pod. So I'm really excited to be here and to talk about these strategies.
Everyone be sure to like and subscribe, Hit Like a Girl Pod. Yeah, there you go. Wendy?
Hey, Wendy Bonner. I'm a healthcare solution architect. I'm also cloud certified in AWS and Azure as a solution architect. I spent 10 years at Intel, and prior to that, I spent 8 years at GE Healthcare. So a lot of experience in the healthcare field.
Thanks, Wendy.
Hello, everyone. I'm George Morris. I'm the Global Healthcare CIO for Dell Technologies Healthcare Vertical. I've got 30 years in healthcare, over 26 of that as a CIO. I do solutions and strategy for some of our largest customers worldwide, and I do development in the background and have a couple apps out there.
Oh, you got some apps. He's hiding them there. George, maybe you could start us off. And I should mention, if you're watching this live, if you're tweeting, be sure to use the hashtag HITSM, HIMSS22. And then Dell, of course, our host here, loves the Transform HIT hashtag. So check out that. They share a lot of great content as well. But George, kick us off here. What are some of the most flexible IT solutions that you've seen, that you've worked with clients?
So, when we saw COVID come in and we were looking for some rapid acceleration, right? Some of the solutions that we have at Dell, as well with VMware, and trying to ramp up making clinicians from a virtual perspective, were some of the most flexible. We had some of our major health systems in North America triple, quadruple, 10 times the size of bringing in their employees from a virtual perspective. We were supplying laptops and screens as quick as we could make them. But that infrastructure that we built, that VMware and Dell Technologies infrastructure we built, was able to scale very quickly. I've got a organization in my backyard in Chicago that literally virtualized over 25,000 employees, and more than half of those were clinicians into video visits. Wow. Within about 2 weeks. So it was pretty amazing.
Yeah. Wendy, anything you'd add? What's the most flexible thing you're seeing?
Well, I think it's the same as what George was saying, but we saw telehealth and virtual desktop. From the customer's perspective, they needed that at the time COVID hit. If that technology hadn't have been there, it would have not gone as well. Correct. So I know we were talking about these services prior to COVID, but it really took off, as George said, afterwards.
Yeah. Absolutely. Sharice, I think you probably have a little different perspective. What are some of the things you saw?
I do. Well, I think what the pandemic taught us is that we are able to scale things quickly. I think one of the cautionary things, if you think about your stakeholders, is we can, but should we, and how do we get that done? Because one thing we have to think about is security of everything. Also, how people access healthcare now, how we live now. So if you scale something in a way and it's not, you don't get the buy-in from your actual stakeholders, it's not going to be a good thing long term. We did the short term, let's get this scaled, and what we should be looking at are long-term strategies. So we've seen a lot of players come into the field. What I'm kind of looking forward to is seeing the long-term strategies, the data strategies, the security strategies, and that type of thing. I think those are the models that'll be here.
Yeah. So Heather, I mean, you have an interesting perspective from a monitoring standpoint and being flexible that way. But let's start diving into that. What are the long-term implications of, I virtualized all this, or I bought 1,000 desktops, or I implemented, or even on the other side, if they didn't do it, what does it mean?
Yeah, I mean, before I go there, the thing I think is really interesting, right? Like, if you look at the world of virtual ICUs, virtualized care, everyone's been very cost prohibitive. They're like, oh, we can't do it. There's a lot of skepticism. There's a lot of things where like, no, I have to be at the bedside. What COVID did is it thrust us into the world where I can't be in the bedside. I can't go in that room. My ventilators are alarming. We got people with GoPros on their head to try to get the data out, because there's a staggering number that people don't realize. In a critical care bed, literally 900,000 samples of data every hour is deleted, because most of those devices are not networked. So what we really kind of set out to do was look at it differently through software. How do we you're always going to have hardware at the bedside, right? All these devices, we've got how many different brands of ventilators, how many different brands of monitors. And so we bring all that together, and then we say, if we can do it through software, right? Software as a service, and have that cleared as a Class 2 medical device, we can start changing healthcare. And so what we really helped hospitals across the country, it's almost like, you know what? Maybe I'm skeptical, but I don't have a choice. And so all of a sudden, we can do a database change and stand up and have ICU beds in minutes. We've had hospitals like Johns Hopkins literally in days of contract signing interacting that data. So I think what I believe we're moving into is this new age of changing healthcare, because what are we going to do with the staffing shortages we have, right? Yeah. We don't have enough intensivists. And one of my craziest things I heard recently is, even if you could find an intensivist, you may not be able to get housing. You may not be able to afford the housing. So we have to figure out a way where we can get more eyes on patients from any location. And that's really some of the work that we've been doing over the last 2 years. And with the help of Intel, by the way, who actually had a pandemic relief fund and was literally helping to stand up rapid deployment of our solution, working with Dell, because it's a cost of a PC to get 100 patients on a screen, not all these different central stations without the data.
So are those investments going to last, right? I mean, it's interesting, you stood it up so quickly. Are they going to stay in place? Are we going to have to scale them up and scale them back? What's the future look like?
So interesting, if you missed, Roberta Schwartz, who is the Chief Innovation Officer at Houston Methodist, she did a session today, and they were already looking at doing virtual care across all service lines, right? They piloted their virtual ICU, and the next day they saw their first COVID patients. It's now a standard of care. She said it's just part of everyday care. When people get hired, they now know that part of what they're going to be hired for is to do virtual delivery of services. And then you can start looking at, as we move into the new world of wearables, we've got to look at a different way of bringing that into a standardized workflow, embedding it in EMR workflows. So I think it's coming. I think it's shifted because technology can enable it. And really, if we give the right data to the right care provider at the right time, we're going to be able to do a lot more.
Yeah. George?
So to build on what Heather is talking about more from a technology perspective, is what the other thing we think is going to be very important for healthcare organizations in the future is to change the way they're delivering services today. The portfolio of applications that we have in most providers is what we would call a Mode 1, an older application, 3-tier architecture, and the kind of application that was built probably some time ago. Modern applications, containerized, are a little different, right? Stateless, they're developed in a different way. The new world requires IT departments to start being able to transform from a people, process, and technology perspective how they're being able to provide services to an organization in a much faster way. So as you start looking at some of the technologies that are needed to support what Heather talked about, and the services and the people and the process around that, it's really just not even modernizing technology, but it's also modernizing what your organization looks like, what the people process side does. So we have a lot of service now around, and we're doing a lot of focus because we've sold a lot of technology, and we're seeing a lot of people that have used the pandemic to modernize, but we're not seeing them get the investment we were hoping to get. They're definitely being able to scale and do some things, but to the point before, what looks next? Well, we're kind of backing up a little and looking at the people side and the process side to get skill sets modernized so that we can apply these new types of services in an agile fashion and be able to provide new types of ROI to the business, different than what we've done in the clinical organizations than what we've done before. So when you're thinking about what's in the future, think about the people, process, technology, and a now, near, far plan. How do you get from where you are today to being able to support something that's API-based and in a containerized application? Or containerized data, which is some of the things that Heather does from MIC.
Wendy, what else would you add? I mean, where is all of this headed? You know, what does an organization need to do to mature this need to be flexible?
Yeah, the way we see it, we're trying to enable a smart hospital, and that means putting your workloads where it makes the most sense. So modernizing is definitely a big piece of that. Getting to a modernized infrastructure will set you up for the future proofing. You're going to want to do that at the edge. You're going to want to do that in the cloud. So, and then have a single pane of glass. Something like a VMware can help with that, right? Where you can, run it the same way at the edge and also in the cloud. So then you can be flexible, move it where you need to, and have the backups on premises, or the backup could be the cloud, right? So it's a holistic approach, edge to cloud. You got to think about it all in a single mindset.
Yeah. And by the way, anyone watching, if you have any questions, let me know. Happy to incorporate it. Looks like we have Belgium in the house too, which is awesome. Welcome. Glad to have you here. So if you have any questions, let me know. Let's talk about patients. I mean, we're in healthcare, right? Patients matter. Charisse, I know you're really passionate about this as well. So how do you think patients really are impacted by these flexible solutions, for good or bad?
Well, there's some really good effects. So we definitely will see, or are seeing, how patients are able to more solidify their relationships with their providers, which is what we need. So one of the things I always say is that communication in healthcare is where we have all failed miserably. We can all agree to that. And if we can repair the relationship between the patient and the provider, we're doing a good job, no matter what our failures of the past have been. So the flexible solutions we offer allow a way for patients to better communicate with their providers. It allows for better decision making, which helps the patient, and it also impacts transactional inefficiencies and inefficiencies in the systems that prevent patients from getting timely care and getting the information where it needs for them when they need it. So, one of the areas that during the pandemic we saw EDs. Historically, EDs have been treated as, in isolation from other departments. But during the pandemic, we saw that 100% we got to make this work. The other thing we saw was that when we looked at the numbers, the number of patients who were admitted to hospitals, their journey started in the ED. So we had to find ways and solutions that the ED department ran more efficiently, that the providers in those departments were able to document better and find better solutions to secure what's going on there, so that patients, when they present, or better still, if they don't present, if we reimagine how emergency care looks for the patient, if we can design better solutions for that, it's better all the way around for that patient-provider relationship in the future.
Yeah, I think we forget how much impact patients have that they don't even realize. If that doctor's burnt out because they can't get to their workstation to be able to document, and now they're late to the next appointment, or, they can't get access to the information they need to be able to do it. It's amazing the impact, and patients don't have an idea, right? So.
Yeah. Okay. And I say that all the time. People don't care about your solution. They care about how your solution solves that problem for them. So if all your physicians are burned out, that solution does not mean a hill of beans to them, because they cannot work effectively with their patients and in a way that makes them feel fulfilled and makes that patient feel seen.
Yeah, let alone if, 2 docs come down with COVID and now they have to see, 3 times as many patients.
Yeah, it's so funny you talk about the ED, because we were thrust into a world. We know it. ICU beds, they don't have them. They're on hold. They're in the ED. ED they're not trained in critical care. They have way more patients. And so one of the things that we were able to help with that I'm really passionate about, it's a database change to add an ED bed to an ICU nurse, right? So they're able to now all of a sudden provide that level of care with that expertise. Or let's look at all the traveling nurses, right? So we know that we're seeing that there. You got 2 years of experience. I can actually be a nurse with 20 years of experience, and all I need is a Dell PC, but I could be in my office or I can be in my home. I could be on furlough. We literally had clients, now they started doing 120 providers rounding every day over web, over their houses, because it starts to change it. And so I think one of the things that has impacted patients is a little bit of a safety of knowing I actually have a level of a critical care physician or a specialist, somebody that's a cardiologist, that can actually take care of me from any location. And that really hasn't existed before. So,
Well, and it feels like to me, healthcare organizations aren't going to have a choice.
correct.
Like we've always had a shortage of doctors, and they're going to need to be able to use technology to scale to that problem.
Yeah.
It feels like to me. Is that what you see?
Yeah, I mean, I think it's 20, they estimate about 20% early retirement this year of all intensivists, your most senior nurse practitioners out there. It's only going to get harder. And like I said, I think the housing crisis combined with it is a crazy thing that I hadn't even thought you'd have to think about, because those rural areas, even if you could get an intensivist, you're not going to be able to find them to work there. Yes.
Wow.
Any thoughts on the role of AI in order to accelerate or help with this?
Yeah, I
And,
mean, so
you know-
part of our platform is it's a remote monitoring and analytics platform. And so what we do is, because the thing that people don't, as I mentioned, the time series waveform data is not stored. So our platform takes care of that. It's agnostic. We store everything, and then we layer on this remote monitoring or centralized monitoring application. But ultimately, it's actually built for AI. So then you can develop and deploy real-time analytics on top of it back into the same clinical workflow. So that's definitely what we're seeing is, as I said, Houston Methodist, they have, I think, 18 real-time risk calculators running in the back that are going to, detect ahead. They've got an ARDS detector. And we really give the tools for you to build and deploy your own AI rather than just forcing you to say, we'll give you out-of-the-box things, but you can also deploy your own on the same system.
Yeah, Wendy, you want to chime in?
Yeah, so definitely the artificial intelligence is built for helping out with the shortage of clinical staff. And some of the things that I'm seeing, like Heather's saying, this ubiquitous infrastructure is collecting data, and we can get information about adverse events before they happen. So that's one thing, but then also taking all of that and aggregating that data across the population. Now you can identify, you can look for trends within your population, identify and predict risk, like who is at risk of developing, chronic heart failure, or who's at risk of diabetes. And now I can spend some scarce resources to target those particular segments of the population. I mean, it's an age-old story, but I keep hammering on it. It's a good one.
No, I think the tool sets are, to both you guys' points. We got Heather with MIC, and there's a lot of ubiquitous tool sets. But again, I'm going to put a punctuation point on an exclamation point on. It takes a different type of skill set to be able to exploit those types of services to develop that. Most of your major application vendors have opened up APIs. They're doing things so you can start getting the data, get the integration, and put AI layers. But again, you've got to have service folks in your IT department providing the services to support it, and then the linkages in a team to be able to fit it into the workflow. So you can get a great analytic, and I've seen a lot of organizations do really fun things with AI and do predictive algorithms that will do some amazing things, both from a population health perspective, but well within the four walls as well, and trying to make sure that we fend off higher acuity to use those scarce resources sooner. The issue is getting that back into the clinical workflow and at the point of care where decisions made and delivered to make sure it works. So that's somebody that can be able to translate to these traditional EMR applications, these AI applications, and get that back in a way where a nurse or a clinician or a physician physician can do the kinds of interventions they need to do in the real time. They can do it without having to deal with one more alarm. I mean, we all talk about these AIs throw out alarms, and it's just one more thing. It's another alarm fatigue. So it's a different kind of workflow, and Heather's got that in MIC. It's some really interesting things that are built into some of the monitoring that they're doing. But again, that takes a whole different type of service, so you got to think about that.
Yeah, go ahead. Can you,
Oh, here.
George, you had mentioned earlier that some clients are not getting the value that they had expected out of these technology investments. And then you talked just now and then about skills of, I guess, the user community. But these days it seems like it would be more likely that productivity would have increased based on the ability to use some of these tools and do remote patient monitoring. So why do you think, all of you, why do you think they're not seeing the value of their technology investments?
So the technology that we've provided has a really wide breadth of capability. I'll just use the development side of it from a DevOps perspective. Being able is an easy one to pick on from an API perspective. When you have traditional IT folks that are at sysadmins, networking, storage, servers, those kinds of things, they have a harder time being able to translate that into providing some of those services in an automated way. So a lot of organizations think about DevOps as developing apps. Sure, that's something you're definitely going to do. But to be able to do infrastructure as a service, software defined, that's development. That's software. That's DevOps. That's agile. That's taking what I think Google calls a site reliability engineer, an SRE, and being able to take an admin and turn them into an SRE. So the people are in a three-tier architecture. Then on the clinician side, then it's getting those folks starting to integrate in a different process with the workflow. So you've got your data science people working on the AI stuff. You got your technology people developing services to the organization, and then you got your clinicians out there from an applications perspective and the EMR trying to use it. How do you bring together a team and do that in an agile fashion to be able to make that all work? So we get some organizations that do great AI work, great analytic work, but then getting it over the fence into the clinical hands is a different world, and it takes a different skill set. Providing the services so that data scientists can create an AI application quickly takes a different type of person in an IT department to supply, let's call it analytics as a service. So that's the skill set as evolution as a service, one aspect of that. Make sense? Thanks.
yeah, Heather, you want to chime in?
I don't know if anybody else has. Do you have any?
I was just going to say, you're right about like the DevOps and that type of thing. Those people are not intuitive to the healthcare ecosystem, so you spend a lot of time getting them to buy in. And then where I find a lot of organizations fail, the continued education piece doesn't hold value for them initially. So long term, it's a failure, because you have to support any infrastructure, any operations you put in place. You have to support it by continually educating your team, because if you're going to evolve as an organization, if your technology is to evolve, your people must evolve, and we do not invest enough in it.
Yeah,
Here,
and
here.
I just wanted to, again, in this earlier session, it was really interesting because Roberta said it wasn't about developing a virtual ops. It was about change management. It was about this idea that we have to come together as an organization and bring all the players. And again, one of the silver linings of COVID, there's actually a lot of them, right, is we've been operating in silos in healthcare for way too long. Right? And so I think even the silos of not just the technology, but the people, and bringing everyone together, because if we're going to change the way we deliver care, we've got to bring the clinicians, the IT, the operations, everything into one, because that's when we're going to be able to make sure that we effectively introduce technologies that will be adopted. So that was just,
Go ahead, Wendy.
Sorry, just one small thing. It made me think of one of our partners is working in the OR space, and when you're talking about artificial intelligence and you're training that, you're doing machine learning, well, you can do that with your staff. So they're doing that with the surgical staff. They're monitoring them and integrating that education into their whole process, taking what they are gathering from the cameras and what they're gathering from the results and training them on best known methods. And so it's It's like AI for your staff. It's really cool.
Yeah.
Care
Go ahead.
Care Syntax. Yeah.
Nice.
Just a plug for them.
Yeah, so it's interesting because as you describe it, right, I was talking to someone recently and they said AI and machine learning is different. It's, when you implement a network infrastructure, you implement it and the project's done and it just works. So sure, you got to patch it and a few things like that, right? But with AI, you implement it and then it learns and then it gets better and then you got to do it again and then you got to tweak it some more and you got to teach it. And so I think for me, I look at it and I say, that's like a change in mindset about what a project is as opposed to it. And so I think that's one of the fundamental things I've seen is changing that mindset. George?
Yeah, simply, you're dead on. It's the difference between a project and a pipeline. A pipeline, you're going through and you're ticking it off and you're evolving very quickly. A project has a beginning and an end, beginning, middle, and end. And this technology, such again from a skill set perspective, requires something like Agile, requires a pipeline, it requires that DevOps. So you go quick, you go fast, and you scale. And that's the benefits of all this as you change from more of a three-tier, as she said, a three-tier architecture and people, and get it more into a DevOps Agile kind of world. You're now scaling because you've got folks that aren't sitting there keeping the lights on. They're not just tweaking wrenches. They're out there actually moving the bar for the organization. So it's different value prop.
Yeah. Heather?
Sort of operating at their skill level. Yeah. I know that's a big one for you.
Well, two interesting things that, I talk to doctors every single day, right? And it was really funny to me. One of my top surgeons, he said, first of all, docs don't like the word virtual. They don't like artificial. So even in our nomenclature, we're all excited. Oh, AI. They're like augmented intelligence. The other thing is there's been a lot of scared out there, right? Because we've had garbage in, garbage out. Right data, you have to have the right outcome. And so there's also this idea when we get into these really complex populations, you need to start sharing the N. We need to be able to do federated learning because one hospital, we do analytics that do cardiorespiratory prediction on babies born with one ventricle. Well, guess what? One hospital doesn't have that many babies born with one ventricle.
Not enough
so you
data.
got to find a way to have the architecture that is going to allow for that federated learning in a safe, secure, private way so that when we develop an analytic, it's accurate. And that you're not going to have a 50% thing. We've all seen the data, right? And we're not going to call it, but it can't be flipping a coin. Because if we're going to predict something and we're going to predict someone having a cardiac arrest, we better make sure that analytic has the right data informing that model.
Yeah, absolutely. It's not just more data, too. George, let's dive in a different direction. I'll give you the hard question. So, let's talk financials. We got to pay for all this.
Yeah.
You described this amazing, agile, area that you can scale up and scale down. That sounds expensive to me, but to help us understand what is the financial approach, and I think let's just say the elephant in the room. Is this going to balloon my costs?
Yeah, so we are sitting at Dell Technologies. So, yeah, we want to sell some things. But,
we hope it does? No.
Yeah, I hope it does. So, yes and no. So there's a way to attack this in an opportunistic fashion. So the good news is, in healthcare, we got a lot of funding over the last year or so, and we've been able to put in some really amazing things. And I think we have a great foundation to build on. I think the point you made of we got to harden it. We did that too fast. Now what are we going to settle in on? I think the good news is the foundation we put in is hard. How we use it, the processes, and what we're doing with it, I think, is where we have to figure that out. So the platform's there. You do it opportunistically. You have to take it a bit at a time. Now, there's three things we like to think about. First of all, you got to have the North Star strategy that you're going to get to the point to be able to take advantage of some of the things we've talked about today. So no investments go forward without doing that. You've just got to absolutely keep that in front of you. The second thing we talk about is you can't build Rome in a day. So you do it in finding the biggest bang for the buck. And you have to start from a ground floor. And at Dell, we have ways to help you find that depending on where you are from an organizational perspective. So it really fits into current budgets. There's ways of doing this where there may be a couple things where we're not investing enough as the people, like we talked about. That's where it can balloon. We're not used to growing people. You're not hiring them. It's just not happening.
They're more expensive.
Yeah,
now.
and they're more expensive. So you're better off doing a combo of trying to grow them. So you got to invest in your people. That's a place where we're seeing it. So it's not the traditional technology. The third thing is if you do the first two right, there's an ROI. You're going to be providing services faster, in a more efficient way, in a more productive way. We've tapped out a lot of things in healthcare to do with more and the same in the last couple of years. If you want to keep doing more with the same, this is the ROI. This is where you can start seeing we're going to make our smart people even more productive. We're going to move them into things that are more interesting, that we're going to grow their skill sets, and there's an ROI in that, and the business and the clinical organization will see that. We had one organization in my neck of the woods up north where they started this process early on, and they actually did it before COVID. And then when COVID hit, they were able to scale. When they first put this plan in place, they had to ask for money. Last year, they had the clinical organization throwing money at them because they couldn't scale fast enough. They were actually trading nurses for folks working in the IT department because of the value that the clinical group in the IT organization was bringing. So it's possible. It's interesting stuff.
It's amazing. You didn't even talk CapEx. Oh, you don't want to get rid of the nurses? You
I
can't
actually
find
was
enough.
about to make the point that the flexible, more flexible IT actually is working to remove the barrier of travel nurses and full-time equivalent positions. So we don't want to get rid of the nurses. We just want them to be in the system instead, right?
Yeah, and I think, some of the other things when you talk about ROI that I think we've seen is technology consolidation, right? Back to that single point thing. How many things do we have aggregating data? How many things do we have processing data? How many things do we have visualizing data? And then when we look at AI, how many things are we going to put back in the room, right? So this idea of we've seen our clients being able to replace single point risk calculators and pay for software as a service across all beds. So there's something you can do to look at when you get away from that hardware-centric approach, from that single-centric approach, and you apply the underlying architecture to support that, the ROI pays it for itself.
Yeah, go ahead.
Yeah, so that's a good point. A lot of the clinicians that this organization were doing, they were creating clinical informaticists to be able to do that integration. So we're not getting rid of the nurses. There's no way. We don't have enough nurses. I'm married to one, so she wouldn't let that happen anyway.
She wouldn't like that?
No, there's no way. But seriously, that's showing the different kind of organization that you have to have today in a modern clinical IT department. You need these folks that are part of that DevOps team as subject matter experts that you're bringing into play to be able to make these applications work and get the ROI you're looking for.
But infrastructure as a service really is a different mindset.
Totally different mindset.
So tell us about it. What are the benefits and challenges that people need to understand? Because it really is that change of perspective.
It is a change of perspective. So it's getting IT folks to think about anything that they're doing that they love today, tweaking in the box. If I have to touch the box, it's a problem. That's a whole different mindset. So if I'm doing anything repetitive and in any fashion, the way we've got to think about that now is that gets automated, orchestrated, and I'm on to something else. So we don't want to do that anymore. Yeah, you got a cloud architect side of it, huh?
I totally
Go ahead,
am.
Wendy.
So it's about, pay as you go, pay for what you need, pay as you go. And some of the Intel's even doing this where you can, decide how many cores you want, decide how much persistent memory you want, and only what you use, and so it gives you a lot of flexibility. You can try new things. You can try all the newest technology that's out there as a service. You don't have to invest a lot right up front. So a lot of flexibility and innovation can come out of that.
Yeah, so it's also a different mindset for your CFO, especially for a nonprofit, right? Thinking on OPEX versus CAPEX. Most of it have to fight for OPEX every year. Everybody wants a decrease in OPEX. So you've got to bring a different model to the table. So it's not only thinking differently about the process, but to your point, the financial side. And I think you'll find both Dell, Intel, most of the organizations have flexible models now from a financial perspective where you can eat it as a service, you can use it as a service, or if the traditional capital's out there, you can start small and scale. All these solutions you can start small and scale now.
Yeah. So as we wrap up here, let's talk about what are some of the solutions, the partnerships that people should be looking at, to prepare for what's probably going to be another emergency. Now, it may be a hurricane, it may be something other than COVID, let's hope so. But, what suggestions would you have to an organization to make sure they're prepared? Charisse, do you want to start us?
I think some of the solutions I would look at and some of the collabs would be how can we triage faster and outside of the clinical setting. One thing that I believe is something that a lot of organizations don't focus on that they should, where they can get a lot of bang for their buck, is the pre-registration process. Now we know that we can 100% register patients from home. However, during COVID, we were still telling patients, you need to go to the emergency room to be seen. That's an area where it's ripe for disruption, ripe for development, and where we can remove some efficiencies out of the system faster. So that's one of the areas where I really feel like is a good area to start.
Yeah, Wendy, what would you add?
Sure. Well, I wouldn't move away from the things that we did during COVID. I would, stay with this virtualization and the web access, the telehealth, and I said this earlier, but I would also modernizing the infrastructure is a investment in the future, right? So you're going to be able to take advantage of that and make you more flexible and give you more options. You don't know what's next. Really, I don't either. So
yeah, that was one of the big lessons. If you hadn't invested in your infrastructure before COVID, you were in trouble. Whereas those that invested were more successful when it hit. So
yeah, the hybrid strategy is where you have to go. You got to be able to scale both within and outside and take advantage of that. So you've got to strengthen your partnerships with both your local vendors as well as some of the cloud folks. Invest in applications that can scale quickly. Again, we've got these folks up here because that's what they do. It's taking what we've got, take those lessons learned, harden it, and then have the capabilities in place, have the contracts in place so that if you've got to react, you're able to do that in an emergency fashion.
Yeah, we haven't mentioned security. When people hear flexibility, they're like, wait, does that make it less secure? You want to comment on that, Wendy?
absolutely not. You have to consider security. And, Heather talked about federated learning. You can share data in a secure fashion. That's obviously improving the models that we're creating. Security's throughout everything. Don't forget about security, and don't feel like it's someone else's responsibility. It's everybody. Everybody has to chip in and take care of it.
It's a culture of security.
Healthcare spends a whole bunch of money with detecting and containing, right? We don't do a lot on the recover side. So we spend a lot of time at Dell looking at the entire continuum of security. But one of the places that I can say we'd like to see healthcare invest more in, good news is you have the cyber vault. The bad news is it's an air gap solution. The bad news is how are you going to recover out of it? What's your clean room look like? What's your tier 0, tier 1 infrastructure plans? So how can I very quickly get virtual and be able to open my data center back up and get the connections back up and running so I can get those virtualized clinicians that the applications like MIC support. So lots of organizations are doing really amazing things to make sure they've got a backup, to make sure they've got plans that they're running tabletop drills and doing all this good stuff. What we're not seeing them do is actually recover and test that recovery, model it, see how it's working. Because I think if it did happen, it's a matter of if. It's not a matter of when these days. It's going to happen to you. You got to be able to quickly recover, and you got to keep that in mind. And folks aren't investing in it.
Yeah, I think it's fair to say a ransomware incident may have had even more impact on an organization than COVID, which is that's saying something.
Yeah, my last interim CIO gig was at an organization that had ransomware very early on, pre-COVID, and we were hard down for 3 weeks. We were soft down for 90 days, and we were still recovering 9 months later. So, lessons learned is got to be able to recover.
Charisse?
I think one thing that I would add is that healthcare is still very reactionary. So a lot of the organizations with the ransomware and they are reacting to a situation, but when you go to them initially and say, you really need to protect against it, they don't see the value in that because of the money they got to spend up front. So convincing them that we need strategies that prevent these things from happening and for that to be a continuing process internally is where the challenge is. But it is the most valuable to them because these attacks, once they happen, the recovery, while it's needed, shouldn't have to be as dramatic as we're seeing.
Yeah, that's fair. Heather, you want to chime in, Heather? Not necessarily on security, but back to the solutions and partnership. What do you see? I mean, what's your view as to what healthcare organizations should be doing? And we didn't talk enough about what about people who haven't implemented this? What does it mean for them?
Yeah, I mean, I think what we really look at coming in to do, we're enhancing what you've already paid for. We're enhancing the monitoring investments that you've already made. We're not trying to overhaul it. We're trying to make sure that we can give access to that bedside data to anybody that can do it. The other things is looking at, of course, our technology partners, right? So we have the software, but we're not hardware providers. We're not the infrastructure providers. We need storage. We need compute. We need endpoint devices. We need safety. We need security, right? We need all of that for the massive data that we're actually collecting. And then, some of the world we're moving in, we partner with all the device manufacturers. We partner with video technology. That's huge right now. Video is really important if you're going to start to virtualize care. So, and then of course your EMR, right? That is the central point. And so this software approach allows you to integrate as an option into those existing workflows. So it's about breaking down the silos again. It's like, let's make what you've already invested in better. Let's look at things we can maybe get rid of that you don't need to. Are you duplicating things? Are you paying for something you don't need to pay for? And then partner is, I think the more we do this, where we all partner together and really work together for the benefit of the hospitals, is the benefit of patient care, right?
For sure. Well, and my favorite technologies that I see are ones that include multiple. Just as you said, they have video, they have the data from the devices, they have the analytics, you're displaying it on dashboards, you're using the compute power, that's where the magic happens at these places, and that's where we really have an impact. And you don't want to do all of that. You need partners. So it makes a lot of sense.
Right. We're the software and monitoring. We're taking care of the data. We want everybody else to take care of everything else, right?
Yeah.
And I think when you're using software, which has been similar to the ROI story that you talked a little bit about, we too, right? We're used to we are software as a medical device, right? We're cleared as a Class 2 medical device. That's traditionally been capital. However, a SaaS-based model means I don't have to buy a central station at $70,000 and all these other things and get hardware in the room. I mean, John, it literally is a database change that changes the paradigm, but means I can pilot very fast, very quickly, at a lower cost. Yeah. So that barrier comes down too.
Well, and the CapEx, OpEx is so important these days. So.
Yeah. I think I think the financial budgets are gonna have to shift a little, right? I mean,
they will.
More and more stuff is moving to the OpEx world.
Yeah.
So.
George, do you want to kind of wrap us up as we can? Thanks everyone for being here and watching live. But George,
no. First, I wanted to thank the panel. I think this has been a great discussion. I think you've gotten some really good perspectives. It's a very well-rounded view. So thanks everyone. We appreciate it. Over at the booth to our right, we've got a lot of these solutions highlighted. We've got our global experts from healthcare available for you to talk with. I'll be over there as well if you want to tap me on the shoulder. Please stop by. We've got some amazing demos as well. MIC is over there, so you can take a look at it. But thanks again, everyone.
Thanks, George, and thanks everyone for watching. And if you want to stick around, I'm sure we'll be here and we can say hi and take a selfie with Charisse. She's the selfie queen, and But thanks everyone. We'll see you at the show.